what Dr. Kamal Pandian has just So this is the picture which will give you a very easy method of understanding how this Iabp works. So this is a catheter with a long sausage-shaped balloon which is inserted via the femoral usually, even though the other approaches are there. The common route of insertion is the aorta, and the balloon is placed in such a way that it is below the origin of the left subclavian. All of you know that right subclavian comes out from the innominate, which divides into right subclavian and right carotid. Then you have left carotid, left subclavian. So it is located on the just the arch of the aorta. When it descends as a descending aorta, is pushed up to that point where the left subclavian takes origin, and it offers to reduce the afterload during systole and increase the cardiac output when the balloon is deflated. And during diastole of the heart, the balloon is inflated. You can see this is fully expanded with the helium gas, and that increases the coronary perfusion and diastolic pressure. So the cases where coronary perfusion is compromised, this will definitely improve the coronary perfusion. And the deflation and inflation are timed according to the ECG pattern. R wave indicates the left ventricular systole, QRS complex. So at that time, it will augment and it will start deflating. And during diastole, when there is a recovery, the ST segment, then the balloon will inflate to increase the, you can see the dichrotic notch going up, pushing that. I'll show you another picture where it is how it augments the diastolic perfusion of the coronaries. So indications is acute congestive heart failure with hypotension, prophylaxis and adjustment treatment of high coronary intervention, myocardial infarction with decreased left ventricular function. So all of them are to support. It is some sort of left ventricular assist device that you can call. And in low cardiac output state after coronary artery bypassing graft, as a bridge to definitive treatment following conditions where there is intractable angina or ischemia. So these are all the mostly to support the left ventricle and coronary perfusion. That is the simplest way to keep in mind all the conditions that are leading to that. Contraindications are uncontrolled sepsis, uncontrolled bleeding, moderate to severe AR, aortic aneurysm or aortic dissection, severe peripheral vascular disease, especially in iliac grafting suprainguinal vascular disease, where that has been prepared with a graft and all those conditions. You should not use this. Technique of insertion: first, sterile preparation of the femoral catheter site, which is the common site for insertion. And after infiltration of local anesthesia, a special needle called angiographic needle is inserted into the common femoral artery at an angle of 45 degrees. Then mostly it is the Selinger technique, and all of you must be familiar with the centerline insertion, where you insert the pilot needle into the vein, IJV, and then once you get the aspirate the blood, you insert the guide wire. And after inserting the guide wire to adequate distance, you remove the pilot needle which you use to identify the vein, and then use a dilator over that and then make a passage, and then remove the dilator and insert your central catheter and remove the guide wire. So that is the Seldinger technique that you use. And before inserting the dilator, you make a small nick at the skin so that the passage of the dilator will be easy. Same way you do here also, but here you use two guide wires, which I will show you. First, you use a J-tip 0.35 guide wire and advance it through the angiographic needle. Then the angiographic needle is removed with the guide wire being left in place. Then you make a small incision with the help of blade, and then at the insertion site to facilitate the insertion of the sheath introducer, and the introducer dilator is inserted. Up to this is just like your central vein insertion. And once the dilator sheath is introduced, you advance the rotator in a fashion into the femoral artery. And once the introducer sheath is placed over the guide wire is removed, leaving the introducer sheath in the arterial lumen. So up to this is something similar to the central vein placement. But after that, what you do is you insert a J-tip Iabp guide wire through this dilator. So the second guide wire is used to thread the Iabp catheter, and this guide wire is advanced up to the thoracic aorta. And the balloon preparation is done by deflating it with the help of a syringe and applying aspiration. And the central catheter lumen is flushed with a sterile saline to ensure patency. Then the Iabp catheter is inserted and advanced over the second guide wire which you have introduced up to the proper position that you need. And once the tip of the catheter is distal to the left subclavian artery in proximal portion above the origin of the renal arteries, then it is considered the safe zone. You confirm the position by chest X-ray or fluoroscopy. Then you remove the second guide wire through which this Iabp catheter has been inserted, and the central lumen connected to the transducer to measure the intra-aortic pressure. And the balloon is connected to the inflating mechanism in the console. So these are the connections that have to be made. Complications can be classified as to complications during insertion, failure to advance the catheter beyond the iliofemoral junction, or aortic dissection, aortic perforation, accidental femoral vein cannulation. All these things are mistakes that can happen during insertion. During use, it can be infection, perforation, balloon rupture, gas embolus of helium, hemolysis, thrombocytopenia, etc. And during or after removal of the catheter, once the patient is weaned of that, it can result in hemorrhage, pseudoaneurysm, AV fistula, entrapment, and inability to remove the catheter. All these complications have been described. And causes of decreased augmentation. Why sometimes even after insertion of the Iabp, conditions do not improve is balloon not needed any longer, or maybe it is a recurring myocardium or balloon rupture, or patient has gone into distributive shock. In these conditions, there will not be much of augmentation by using that. When to wean from that, inotropic requirement should be minimum, and reducing the ratio of augmented to non-augmented beats from 1:1 or 1:2 or less. And what is the reason for helium being used to inflate the balloon? Any idea, Dr. Kamal? Why not use air?
Sir, maybe because it has a lower density, sir.
Lower
Density?
density, yes. So what happens? You are correct. It has a lower density. What is the advantage?
Mm-hmm.
Right. So helium is used to inflate the balloon because of lower density. So less turbulent flow as the balloon gets inflated, and the inflation will be fast and reflate slowly, okay, because of this factor of low density. And also it is a benign, it is called the inert gas. And so it will not cause any problem even if the balloon ruptures and the helium mixes with your blood, nothing will happen. And this is the picture of the tracing, tracing of the waveform. So here you can see this is the unassisted aortic diastolic pressure here. Then this is non-augmented systolic pressure. This is the natural waveform of the aortic pressure. Then when it comes down at the dicrotic notch level, the reduced aortic end diastolic pressure. This is the dicrotic notch which is there. So here it pushes up and augments the diastolic pressure. So you can see instead of coming down, it goes up, then it comes down, and then reduced systolic pressure is happening. So this blue line shows how the curve is altered. So normally arterial waveform should go for a systolic peak, then it should have a diastolic dicrotic notch, then it will come down to the diastolic phase. So here what happens, the diastolic slide or slope is pushed up to improve the pressure on the diastolic period also, and then immediately deflates to assist the next systole. So this is the change that is happening in the normal compared to the. So this blue line indicates how the normal arterial waveform should be. Instead of that, at the dicrotic notch level itself, the diastolic the downward slope is pushed up. So this is what is happening. And if you get a waveform like this, then only it is indicative of the normal pattern of the thing being working. Okay. So this is an ASCII slide I prepared long back using this. So some of the questions that are here, what is shown here, can you answer? This is the intra-aortic balloon pump screen display. What are all things being shown here? Now display on the monitor of a Iabp machine. What is Iabp? Of course, we have defined it's a temporary, coronary and systemic perfusion assist device. What is the basic principle and physiological effects? Of course, he described that synchronized counterpulsation in the basic principle, inflation during diastole and deflation during systole of a balloon placed in the descending aorta. This helps to improve myocardial oxygen supply and reduce the myocardial oxygen demand. What are the indications for its use? We have seen that to prevent it for cardiogenic shock secondary to AMA, refractive medical therapy, and mechanical complications. And the indications where it may be of high risk CABG, cardiac patients for non-cardiac surgery and decompensated aortic stenosis. Contraindications, interlude, aortic regurgitation, aortic dissection, aortic stent, bill femoral popliteal bypass and stage cardiac disease. And relative contraindications are uncontrolled sepsis, aortic aneurysm, bill peripheral vascular disease, ileofemoral stent coagulation. The waveforms that are displayed in this are, the top is the ECG and the middle is the aortic waveform during augmentation, which I showed in the previous slide, and bottom is the balloon pressure waveform. So these are all the three waveforms you will see in the display of the monitor. Okay, so supposing this sort of questions come in OSCE, it should be helpful for you to answer that. Okay, right. Shall we finish the last